Thank you. Dr. Miller, so, well, actually, for any of the panelists, appreciate everyone's testimony this morning, and certainly focus on the ACO model, which is something big in the Pacific Northwest and has yielded, some great efficiencies as they've tried to move towards that, and certainly we'd like to leapfrog towards that as soon as possible. But we did write into the Affordable Care Act a value-based payment modifier that CMS is putting out rules, preliminary rules on now, and would be implemented fully by 2017 as a process for getting off of fee-for-service and focusing on outcome-based results. I didn't see much of that in anybody's testimony, so I'm just wondering what people are thinking about that, or as I said, we'd certainly love to leapfrog to ACOs, but getting off of fee-for-service and focusing on better outcomes and rewarding people for better outcomes at oftentimes at lower rates, we think is where we need to be going in this short term.
Right, and I think what I would say is that we understand, I think the Commission's view is that they understand the concept, the notion of trying to reward a provider for efficiency and high quality, low resource use. I think some of the concern about that particular modifier is how accurately it can be put together for an individual provider. I'm not real deep on this, but my sense is the first wave of implementation that went out on it, that CMS was saying for groups of physicians, because there was some concern on the stability of measurement. And one of the things about an organizational structure of some size is you get a lot more stability when you look at quality and efficiency that way. So one of the concerns with the modifiers is how stable it can be for any given provider.
And I'll just add, so for the beginning of the program, you have to have at least 100 eligible health professionals. So to Dr. Miller's point, you need not only the size, but in terms of the measurement for 2015, they'll be using performance year 2013. So we're still seeing kind of this lag in getting physicians information about what they could be doing at kind of a real point in time. But we think it's an important step in the right direction to get you closer to taking on more of the risk.
Well, this was, a lot of part of the debate. I know because obviously it was my language, and this is a philosophy from the Northwest. I mean, sure, we'd like to get paid more. Sure they would. But we gave up on that a long time ago because we're more efficient and we have better outcomes. So now all we want is the rest of the nation to move towards that same level of efficiency so we're not penalized, so that physicians don't go practice medicine somewhere else just so they can get paid more when we actually have better outcomes. So we knew that the individual physician, I mean, that was part of the debate among committee members too. They knew that if you isolated it down to that level, it would be somewhat problematic. And we get that there are maybe regions or parts of the country that may be, more uniquely challenged to face this, but we're talking about billions of dollars of savings here if you move off of fee-for-service. And as I said, we'd leapfrog right to ACOs because we're ready to go there, but I don't know that everybody else is. So we definitely believe that the index should be put in place. We will certainly be working with everyone to be more vocal about it because we do think it's an important interim step. Dr. Miller, on the kind of efficiencies that you think we can get out of ACOs, do you think there's enough savings there to then take those savings and focus on graduate medical education so that we can prioritize the volume that we need for primary care physicians?
I've not thought about the issue in that way, and I would be very hard-pressed to tell you what kinds of savings to expect out of it. What I can say is that the Commission put together a proposal, it's a few years back now, I'm forgetting exactly when we put it out, but the notion on graduate medical education is to, instead of having this kind of blind focus on slots, which are producing more of the same, when all of us at the same time are saying, but don't we need a differently organized delivery system? We had a set of recommendations that would use those resources differently and direct them to graduate programs that are more focused on systems, focused on primary care, focused on rural types of care, so that we would get better accountability out of the graduate medical education dollars that we're spending. Like I said, it's been a few years now. I'm not quite on top of that, but I hadn't thought about it in the context of the ACO.
But do we need, given the demand that we're going to face, do we need to dramatically increase the number of GME slots for primary?
Our point has been twofold. One, be sure that the graduate medical education dollars that are being spent now are directed towards accountability and producing more of the types of professional that operates in a system-based care. If you're going to add slots, then at that point, then think about which way you want those slots to go and what you want them to be devoted to. Our basic concern is just adding slots gets you more of the same in the current system.
Thank you, thank you. Thank you very much, and I'm sure that my colleagues would love to see, any recommendations that you're making on this area moving forward, or as soon as possible. Without seeing any of my other colleagues here, I'm going to adjourn the hearing, but thank you so much for your testimony this morning. This is a critically important part of our delivery system reform, and becoming more efficient and using those dollars to drive better quality at lower cost is going to be critical to the entire country. So we look forward to receiving more input from all of you. We're adjourned.